you will just bear with me for the couple of 5 minutes coming. I will talk to you about a new research project, gender-sensitive measures for women in substance treatment services in Flanders, the Flemish-speaking part of Belgium. Where does this come from, this project? It's a follow-up project or a study of the GenStar study. In the GenStar study and the international literature, we see that there is a lack of gender-sensitive services for women, outpatient as well as residential services. We also see that there are several barriers and facilitators for women, such as, for example, childcare and children, such as health issues, social network of family and friends, custody, the stigma, the social stigma, and the self-stigma. But we also see that there are specific needs in treatment for these women. So women report to have specific needs. For example, they want to feel safe in treatment, they want to have peers surrounding them, they want to have an expert by experience in treatment, they want a holistic approach. So these are the things that we know from the scientific research project, GenStar. But of course, now what? We have the results, we have the academic scientific findings, so what's next? We didn't implement something, we didn't have a change in the field, so this was actually, we thought that this was lacking the Belgian or the Flemish structure. So the Flemish-speaking researchers of the project thought that it would be interesting to do something with these findings. So we found funding for a 3 to 4 year project to select a gender-sensitive measure for women and to implement it in 4 settings in Flanders. So it's a 3-year study, and the study's acronym is GenSum, referring to GenStar, but with a focus on the support for women. So 4 researchers are involved, including Wouter van der Plassen, promoter of the GenStar study. And it's conducted by the University College of Ghent. What is our research question? The research question is what gender-sensitive support can incite the alcohol and drug treatment toward more qualitative demand reduction services for women. So we have identified 4 goals. The first one is we want to establish a learning community of providers, patients, experts by experience, policymakers, and researchers from the alcohol and drug demand reduction field. Second of all, we want to map or identify national and international good practices of gender-sensitive supportive methods. We want to, of course, select 1 or 2 measures and implement them in these 4 settings. And we want to, of course, monitor and evaluate the process of this implementation. Where do we start from? We start from the pedagogy of the maximum. What does this mean? We want to operate from a strengths-based perspective or an approach instead of a problem-oriented approach. So we want to see women as active actors and as experts of their lives. We want to focus on their capability, their capacity, and their skills. We also want to operate from a pedagogical perspective instead of a traditional medical perspective. So we want to start from a supporting model. And we want to start from their own perspective, their own framework, their own reference. And by doing that, we want to reduce the distance between the service providers, and the patients. So we are using a very challenging research method, but we also think at the same time that it's a very rich method and it's a powerful method. It's a participatory study in which providers, researchers, experts by experience, but also policymakers and researchers work together as co-researchers. So the study population are female former substance users or current substance users and providers of 4 services in the alcohol and drug demand reduction field. These 4 services, we call them experimental gardens. So these are the 4 services. Wrong button. These organizations are deliberately chosen and they are balanced mix in several ways. So we have outpatient and residential services. We have services focusing more on alcohol related problems and others on illegal drugs related problems. We have services single gender services and mixed gender services. We have services along the continuum of care like harm reduction, treatment, and aftercare. And we have services in which women can get treatment with their children and services in which women can get treatment without their children. Another powerful aspect of the project is that we're operating from, or that it's carried by a learning community. Who's in the learning community? 1 to 2 providers of each service and 1 to 2 experts by experience or clients or patients. There's also a policymaker in the learning experience. Of course, the research team is there as well. And what's important is that we do each learning community on location. So we do it in the several 4 services. This makes it very interesting for the services itself because we always start with a short introduction of what is the service about, what is the program about, what are they doing here, for who is it meant to be. So they're learning from each other, which is very interesting. Actually, since the project has started, we've had 3 learning communities so far, and there have been referrals between the outpatient and residential services, so that was great so far. So why are we using a learning community, and I'll wrap up after this, is because we want to maximize the chance that there is a sustainable implementation in these 4 services. So we want to make it like a long-term goal. And of course, because of the sharing experiences. So this is our project in a nutshell. We're still moving forward in the project, so I'm very anxious telling you in 3 years how it's all going to wrap up. Thank you.